Let's move on to pleural pathologies. And within pleural pathologies, we basically will be talking predominantly about pneumothoraces, pleural effusions, and empyema. Now, a pneumothorax represents, as we all know, the pneumothorax represents accumulation of air in the pleural space, and it may occur spontaneously or secondary to a trauma, or in certain cases because of an underlying lung pathology such as cystic fibrosis, pneumonia, ARDS, or even in patients who've got specific types of pneumonia like a PJP pneumonia. Um, we all know that air will usually rise to the non-dependent position, and the radiographic appearance of a pneumothorax will depend on how the radiograph has been exposed. So, say for example, the patient's X-ray has been taken in an erect position, then the air will rise to the anterolateral, or maybe more towards the apex. So it will be apicolateral surface of the lung, and usually it will appear as if there is a pleural line without any lung markings beyond that pleural line. The underlying lung will obviously collapse because the air in the pleural space will result in rise in the pressure within the pleural cavity, and therefore it will result in collapse of the underlying lung towards the hilum. Um, Tension pneumothorax is accumulation of air within the pleural space, which obviously results in significant hemodynamic instability. The diagnosis of tension pneumothorax is pretty much based at the bedside on clinical scenario, and the most important thing that we need is a large pneumothorax with hemodynamic instability. On occasions, patients can have a smaller pneumothorax with significant hemodynamic instability, especially if the underlying lung is diseased. Um, a diagnosis of a tension pneumothorax at the bedside can be based on the fact that there will be significant shift of the mediastinum to the opposite side, including shifting of the heart as well as the trachea. There will be depression of the hemidiaphragm as well as a shift of the superior vena cava and the inferior vena cava. And this can be easily seen on a chest x-ray. In an ICU patient, however, diagnosis of a pneumothorax is often made on a supine radiograph. In a supine patient, the air, as we all know, is usually because it goes in a non-dependent position. As a patient is supine, it will accumulate anteromedially. And if you have a patient whose X-ray has been taken in a supine position and that demonstrates an apical air collection, it indicates the presence of a significantly large pneumothorax. Um, on occasions, air can sometimes be trapped in the subpulmonic location between the lung and the diaphragm, and this will make the margin of the diaphragm quite clear and quite sharp. Um, and on the other hand, there could be an anterolateral extension of the air into the costophrenic sulcus, and this may result in a radiolucency of the costophrenic sulcus, which is called as a deep sulcus sign. Other features of subpulmonic pneumothorax includes visualization of the superior surface of the diaphragm as well as the superior part of the inferior vena cava. Now these are all features of a supine pneumothorax. Let's have a look at some of the pneumothorax X-rays. So obviously this particular X-ray demonstrates a large hyperlucency of the left hemithorax. Though the pleural line is not well visualized, we can't really see lung markings within the left hemithorax, and the underlying lung appears to be collapsed towards the hilum. It's interesting to note, however, that the mediastinum itself hasn't really shifted to the right side as you would expect with such a large pneumothorax. This particular X-ray demonstrates the presence of a right-sided hyperlucency with possibly a deep sulcus sign. There is a right-sided chest drain which hasn't really drained the pneumothorax completely, as well as we can clearly see that the underlying lung is collapsed towards the hilum. This particular X-ray demonstrates again a left-sided pneumothorax with a hyperlucency all around the lung, but particularly in the subpulmonic location, and there's a deep sulcus sign, as well as the underlying lung appears to be heavily consolidated. Even the right-sided lung appears to be heavily consolidated. There is a right-sided chest drain as well, indicating that the patient probably might have developed a right-sided pneumothorax, which is why the chest drain is in place, and the patient is obviously ventilated with the endotracheal tube too far down the trachea, quite close to the carina. Um, the next X-ray shows that there are lung markings right up to the edges bilaterally. However, you can clearly see that there is an evidence of hyperlucency in the subpulmonic location, which makes the right-sided diaphragm quite clear, as well as there is evidence of hyperlucency within the right sulcus, indicating that this is a deep sulcus sign. And as the patient is, the X-ray itself has been labeled as a supine X-ray, and the patient is intubated. This would suggest the presence of an anteromedial or an anterolateral pneumothorax, which is why the lung doesn't appear to be completely collapsed. Um, on the other hand, this particular X-ray demonstrates a significant hyperlucency on the right side with a deep sulcus sign. There's an extreme shift of the mediastinum towards the left, as is clear by the fact that the endotracheal tube itself is shifted towards the left. The left-sided internal jugular vein, which is the tip of which is sitting in the superior vena cava, is also shifted towards the tip is shifted towards the left. The heart itself lies in the left hemithorax, and there is possibly a depression of the right diaphragm. All these features are suggestive of a possible tension pneumothorax. Let's move on to the next pathology, which is presence of pleural effusions. Now, pleural effusion tends to be used as a catch-all term, which basically means that it denotes collection of fluid in the pleural cavity. We all know that the pleural effusions can be further divided into exudates and transudates depending on the biochemical analysis, and the fluid itself could be anything such as blood, chyme, pus, transudate, exudate, and so on and so forth. Chest X-rays are the most commonly used examination to assess for presence of pleural effusion. However, it should be noted that a routine chest X-ray, which is performed in an erect position, will require as much as 250 to 600 ml of fluid before it is required, before it can be evident on a chest X-ray. And this is particularly important to know, because obviously by the time you start seeing a pleural effusion on an AP chest X-ray or a PA film, the pleural effusion is already moderate size. And that is because the posterior costophrenic sulcus is actually much deeper than the lateral costophrenic sulcus, which is why the fluid accumulates in the posterior costophrenic sulcus, which is not very evident on an AP or a PA chest X-ray. A lateral decubitus film is the most sensitive chest X-ray, which will be able to identify even a small amount of fluid, because obviously the fluid will be in dependent position, and therefore a lateral decubitus film will show a fluid at the bottom of the chest X-ray. When the effusions are not readily apparent on supine chest X-rays, but we clinically suspect that a lateral decubitus film is indicated. Now we are rarely going to see a lateral decubitus film in an ICU patient. Therefore, it's all very academic for an ICU population, and therefore we shouldn't be paying too much attention to this. Now, within whatever we see on a routine basis, what we see is an erect patient chest X-ray. And in this particular population, what we're going to see is there's going to be a homogeneous density, and because the fluid will accumulate in the dependent position, an erect patient will accumulate at the base of the lung. There'll be costophrenic angle blunting. There'll be decreased visibility of the lobar vessels, which means you won't be able to see much vessels because of a dense homogeneous opacification. The lung will collapse towards the hilum. On occasions, you can get large pleural effusions where there will be a complete shift of the mediastinum to the opposite side. And this may represent the presence of a tension pleural effusion. However, that terminology is not commonly used. And a locular pleural effusion, on the other hand, is a pleural effusion which is basically can result in a significant diagnostic challenge, especially if the effusion is lying in a fissure, or or even if the patient has got a right middle lobe atelectasis and a fluid in the fissure, it might be very difficult to differentiate. But a local pleural effusion is the one which where there are lesions within the pleural cavity, and the pleural effusion itself is not as free flowing, and there are multiple locules of collections of fluid, and these particular pleural effusions appear as homogeneous opacification or densities with biconvex edges. We'll see some examples of that in the next few slides. On the other hand, on as we talked about pneumothoraces earlier, quite a few patients will have X-rays done in supine positions, and supine pleural effusions are something that we need to know about as well. And what it results in, there are certain signs that have been used in neurological literature to point towards supine pleural effusions, and these basically have been called as an increased homogeneous density superimposed over the lung. There could be loss of the hemidiaphragm silhouette, there could be a blunted costophrenic angle, or there could be an apical capping. If you get a blunted costophrenic angle or an apical capping on a supine film, it indicates the presence of a very large pleural effusion. There could be elevation of diaphragm or decreased visibility of the lower lobe vasculature or accentuation of the minor fissures, and all these things are very difficult to visualize. What's the most important thing that we need to remember is there is an increased homogeneous density superimposed on the lung or the lung on the side of the pleural effusion. Um, let's have a look at this particular X-ray. This X-ray shows that there is evidence of homogeneous density on the left side with obliteration of the costophrenic angle, and it kind of rises a little bit towards the axilla in an S-shaped pattern, and that and in a concave pattern, and that basically indicates the presence of a pleural effusion. On the other hand, this particular X-ray demonstrates that there is an evidence of a homogeneous density with lack of lung markings on the right side. The right costophrenic angle is not well visualized, and there is a possibility of a right lower lobe collapse as well. And this homogeneous density is biconvex in appearance. There's also presence of a bit of homogeneous density towards the on the rest of the right hemithorax, indicating that there is a loculated pleural effusion, but there might be a free component as well. If this particular X-ray has been taken in a supine position, there's no way to know that because obviously it's not been labeled that way. On the other hand, this particular X-ray, we can clearly see that it's been labeled as a supine chest X-ray, and there's a homogeneous opacification of the right hemithorax. There is also blunting of the right costophrenic angle, and obviously it indicates that we can't really see the right diaphragm as well, indicating that there is a presence of a supine pleural effusion on that side, and probably is a large size because you can't really see you can't see the right costophrenic angle or the diaphragm, as well as possibly there is an apical capping as well. Apical capping is nothing but presence of a homogeneous opacification of the apex with lack of lung markings. The next thing that we can sometimes see in patients with pleural effusions is what is called a hydropneumothorax. A hydropneumothorax is a term given to the concurrent presence of a pneumothorax as well as a hydrothorax or a pleural effusion, indicating the presence of both air as well as fluid in the pleural space. And it may arise from a number of due to a number of reasons. One of them is obviously post thoracocentesis. So if you've done a chest drain insertion in the patient and you've inadvertently inserted air into the patient's pleural cavity, it results in presence of a hydropneumothorax. On occasions, you can get a hydropneumothorax or a hemopneumothorax in a patient with thoracic trauma, or in patients with bronchopleural fistula or in esophageal-pleural fistulas. And the classical finding on an erect film is nothing but an air fluid level. On the supine chest films, this might be really difficult to diagnose, and therefore it should be diagnosed on an erect film. Pneumomediastinum. Let's talk about a little bit about the pneumomediastinum. Pneumomediastinum represents air in the mediastinum and may be related to either a pulmonary interstitial air dissecting centripetally in the intubated patient, and the pulmonary interstitial air could arise either because of barotrauma, lung injury, and so on and so forth. The other possibilities or possible causes of pneumomediastinum include a major airway injury such as trachea or a bronchial airway injury, or an esophageal injury or tear which results in escape of air, as well as there could be air dissecting from the retroperitoneum. Again, this is quite rare, and majority of the causes would include either pulmonary interstitial air or a major airway injury or an esophageal injury. Now, the classical findings of pneumomediastinum is presence of air around the great vessels. Especially you can have it around the aortic knuckle, descending thoracic aorta, as well as pulmonary arteries. It is also present on the medial border of the superior vena cava and the azygous vein, and there may be associated findings with pneumomediastinum, and therefore you should basically specifically watch for pneumothorax or subcutaneous emphysema. Pay attention to presence of a pneumopericardium, as well as make sure that you looked at the deep sulcus sign before you say that there's no evidence of a pneumothorax on a chest X-ray. Let's have a look at a few of these slides. Now, this particular patient, you can clearly see that the border of the heart, there is a presence of a hyperlucency right around the edges of the heart, and therefore you can clearly demarcate this particular space between the heart and the lungs, and obviously this is presence of air around the heart, indicating, as well as around the descending thoracic aorta, and there may be a sliver of air around in the neck as well, indicating the presence of some subcutaneous emphysema and the presence of pneumomediastinum. On the other hand, this particular X-ray demonstrates the presence of air around the great vessels as well as posterior to the heart, and this indicates the presence of pneumomediastinum. Again, when you do get patients with pneumomediastinum, there has to be further investigation as to what the cause is, and this would include looking at the underlying pathophysiology of these things. If the patient is intubated and has been a difficult ventilation, then obviously think about lung injury and barotrauma. On the other hand, if the patient has come with a trauma, you think about airway injury or esophageal injury, and so on and so forth. Now, before we go on to the next one, we obviously as an intensivist and as working in intensive care, and one of the most important things that we look at X-rays for is to make sure our equipment is in the right spot. And so we'll go through a few slides and see if our equipment, where should our equipment lie in, and what space is an appropriate spot for all the equipments that we talk about routinely in ICU. So let's talk about endotracheal tube first. A correctly placed endotracheal tube lies at the level of mid-trachea, about 5 centimeters from the carina, and the minimal safe distance is 2 centimeters from the carina. And the reason why we say that the minimal safe distance is 2 centimeters from the carina is because there would be shift of the endotracheal tube within the trachea based on whether the patient is extending or flexing the neck. On flexion, the endotracheal tube can travel inside the trachea for about 2 centimeters, which is why it needs to be at least 2 centimeters from the carina. Now, when we look at the chest X-rays, we need to identify the carina well. On most occasions, where the chest X-ray has been adequately exposed, carina will be visible. However, on occasions it may not be visible, and in these situations an interspace between T4 and T5 will be considered to be the spot where carina would usually lie. On other occasions you may not be able to identify carina at all, in which case there has been a method which people have used but might be a bit too tedious for an ICU use, which is called the D method. And the D method has been devised for approximating the position of carina. This involves identifying the aortic arch and then drawing a line inframedially from the middle of the arch at a 45-degree angle to the midline. Now, the intersection of the midline and the diagonal line is the most likely position of the carina. Again, this is a very cumbersome method and we wouldn't necessarily recommend it to be used on a routine basis. So all you need to do is basically identify the end of the endotracheal tube, identify the carina, and measure the distance between the end of the endotracheal tube and the carina. Or you can occasionally see the end of endotracheal tube. There could be a number of reasons why this is very important, because obviously there is a risk that this particular endotracheal tube may actually travel too far into the trachea and may actually cause endobronchial intubations. And if this does travel into the right main bronchus, then the patients can develop a right or a left lung collapse, as is evidenced in this X-ray at the bottom. Or on occasions, if you have a really enthusiastic endotracheal intubation, and the tube has been pushed in too far, then it might actually end up intubating the right bronchus intermedius, in which case there would be a left uh, lung collapse as well as a right upper lobe collapse. Now, need to be very sure that the endotracheal tube is in the right spot. Now, on occasions, people have missed esophageal intubations and have done X-rays of patients with esophageal intubations, and it may not be very clear as to whether the endotracheal tube is in the trachea or whether it's in the esophagus based just on the chest X-ray, and therefore end-tidal CO2 needs to be performed in all patients after endotracheal tube placements. Now, as we clearly see this particular X-ray, you can see the lungs are probably adequately, inflated. The endotracheal tube looks like it is probably in the right spot, but however, there is a passive gastric dilatation, and it begs the question as to whether this tube was initially placed in the esophagus and has been replaced back into the trachea at some stage. So it's important to basically check the endotracheal tube position whenever you are looking at a chest X-ray. Now, the next tube that we obviously put in all patients who get intubated is a nasogastric tube or an orogastric tube. It's important to remember that the tube needs to be followed to make sure that it enters the stomach below the diaphragm, and make sure that all the holes of the tube, side holes of the tube, are in the stomach, and inadvertent placement in the bronchial tree or too high placement should be sought. Now, normally you would expect that the NG tube tip should be at least more than or equal to 10 centimeters distal to the gastroesophageal junction, that is below the left hemidiaphragm. If it's not, then obviously it needs to be pushed in further. Say, for example, in this particular patient, the nasogastric tube or the orogastric tube appears to be well inside the stomach. You can adequately measure the distance. On occasions, the tube might not be too far in and it needs to be pushed in, as is evidenced over here. And in some occasions, you may find that this particular endotracheal tube takes an acute left turn, and it sits somewhere along the hemidiaphragm. I'm not so sure whether it actually is going in the right spot. Obviously, I think it's probably going in the left main bronchus, is probably travel, and the fact that it's actually the tip of that particular tube is curled indicates that it actually might be sitting in the pleural space rather than the bronchi itself. And this is quite not a common occurrence, but not an unheard of occurrence, especially when you have an enthusiastic residents trying to put fine bore tubes into patients. Similarly, over here, where the nasogastric tube is traveled into the right main bronchus and into the bronchi, small bronchi. On the other hand, in this particular patient, the tube is actually curled back into the left and then again turned back into the right. And I think this is quite a enthusiastic nasogastric tube placement again, I think. Okay. The next catheter that we obviously commonly use is the central venous catheter. Now, for accurate CVP measurements, for whoever using CVP at this point of time, I wouldn't recommend using CVP for any kind of indication. However, at least when you're putting a central line, even if you're not measuring the CVP, it's important that your tip of the central venous catheter is sitting beyond the last valves in both subclavian as well as jugular veins, and therefore it's important that it sits in an appropriate position. But for CVP measurements, what the classical location was, that uh, you know it should obviously be sitting in the superior vena cava. Now, ideal location that it actually should be sitting at the junction between the right atrium and the superior vena cava. If it's placed too high or too low, then it can result in complications. If it's too low within the right atrium or within the right ventricle, it can result in perforation of the right atrium or arrhythmias, and so on and so forth. Now you can see the oval marking, and that's where your tip of the CVC should be placed. Sometimes the central venous catheters can actually travel in the wrong direction. They might go from a subclavian when you're trying to enter into a subclavian vein. They might actually enter jugular vein, so they might actually travel from one subclavian vein to the brachiocephalic vein, or they may even go into the azygous vein. On occasions when patients do get a left-sided internal jugular vein placement of the central venous catheter, the patients might have a persistent left-sided SVC, in which case the catheter might actually go down the left side. And it's very important in these situations to make sure that your catheter is in the right spot by hooking it up to the transducer set, so to make sure that it's all you're measuring is a venous trace and not an arterial trace. In any case, you need to basically make sure that your central venous catheter is situated in the vein by connecting it to a transducer, as well as maybe doing a blood gas through the central venous catheter. On occasions, you can have an arterial placement of CVC, and on occasions, I've also seen patients who have had central venous catheters where it appears that the central vein, it is tracking along the appropriate veins and actually entering the SVC. However, in fact, it's actually the catheter is actually sitting next to the SVC, and it's probably perforated the vein through and through, and the wire has gone into a space, a potential space around the SVC, and it's actually caused the catheter to go into a pleural space. So it's important that you basically look, as well as you use your transducer sets as well as blood gas, and make sure that all the lumens are aspirating and flushing before you confirm the position of your central venous catheters. As far as the position is concerned, the appropriate position is a junction between the right atrium and the SVC. Therefore, ideally, the catheter needs to be on the right side of the midline in the first intercostal, is usually in the anterior first intercostal space. You can also have the you can also use other methods to confirm the position of the SVC by making sure, by comparing it with the carina. It usually lies just the carina as well as the ascending thoracic aorta can guide your placement of the central venous catheter. Now, on occasions, like for example in this particular patient, the central venous catheter is sitting in the SVC, which is where we would expect it to. While on this particular patient, it looks like the central venous catheter tip, which is basically been inserted in the right internal jugular, is sitting way beyond the superior vena cava and probably into the right atrium, and that's actually sometimes a bit dangerous. The other hand, you can have complications where the catheter actually has entered the right subclavian vein, but instead of going into the superior vena cava, it's actually traveled back into the left brachiocephalic vein. The endotracheal tube in that particular patient looks quite high, and this patient might actually be at a risk of self-extubation or even extubation, just based on the fact that the tube is sitting probably at the level of the larynx. On occasion, the subclavian venous catheter can travel. The tip of it can travel into the internal jugular, or vice versa. A catheter inserted in the jugular vein, instead of going down the superior vena cava, it might actually go into the subclavian veins, and this should be actively sought. In this particular patient, the the central venous catheter tip is actually curled at right angles just at the level of carina, and this definitely indicates that it's actually entered the azygous vein. You can basically look at the anatomy of the azygous vein and see where it's actually entering, just at the level of where the azygous vein actually drains into the superior vena cava. That's where it actually can enter into the system and go along the hemiazygous vein system, venous system. We talked about a persistent left-sided SVC, and a left-sided SVC is not common. It occurs only in 0.3 to 0.5% of normal population, and in probably around 5% of the patients with congenital heart disease. And on most occasions, people wouldn't even know whether they've got a persistent left-sided SVC because they're not symptomatic from it. And the vast majority of the cases are usually detected only incidentally, either during a CT scan of the chest or as a result of a line placement. This persistent left-sided SVC may drain into the coronary sinus, which is most common, which is around 92% of the persistent left-sided SVC drain into the coronary sinus. And on other occasions, they could drain into the left atrium, causing shunting enough to cause cyanosis. Okay, we can't really tell whether this particular central venous catheter is actually sitting in the aorta or whether it's actually sitting in the persistent left-sided SVC. The only way you could probably know that is based on a transducer, but you should remember that that's a differential diagnosis for this particular occurrence. Central venous catheter, and on occasions you can obviously have an arterial placement of the central venous catheter. Over here you can see that if this particular catheter was sitting in the brachiocephalic vein, it should have actually, the tip of the catheter should have gone upwards towards the left clavicle. On the other hand, the tip of this catheter, which is going from the right subclavian vein, has traveled across the midline, and the tip of the catheter is actually going downwards, indicating that it is probably an arterial placement of the central venous catheter. And you need to be actively seeing these before you go ahead and consider it. You should basically transduce these particular central venous catheters. So the next thing that we basically are going to talk about is a PA catheter. Now, the ideal position of a PA catheter is that the tip of the PA catheter should lie within the segmental pulmonary arteriole. And when you talk about a segmental pulmonary arteriole, it's important to note that the catheter should not be actively wedging while the chest X-ray is being performed, which means that it shouldn't be it should be less than 2 centimeters beyond the central hilum. Now, there are a number of problems that can come along because of a PA catheter placement. It could be a very distal placement, and the potential is that it can, when you do inflate the balloon, it can result in rupture of the pulmonary artery, or it could also result in knotting or looping of the PA catheter within the right ventricle or the right atrium, as is evidence on the chest X-ray that's just next to the PA catheter statement. And it's important to basically look at and follow the PA catheter when you're looking at an X-ray with one. Now, the tip of the PA catheter, as you can see, it's been inserted to the right internal jugular, which is the most common location through which it actually enters into the superior vena cava, right atrium, right ventricle, and then travels across the pulmonary artery. And the tip of it is sitting in the right main pulmonary artery. And the tip of it is probably less than 2 centimeters from the hilum, and that should probably be an ideal location. On occasions, the tip of it can be sitting way too far into the lung, and the potential is obviously a rupture of the pulmonary artery, which is quite a dangerous thing to happen to the patients. And this particular patient, the tip is actually traveling up into the upper branch of the right pulmonary artery. On the other hand, it could potentially be in the left pulmonary artery. Again, this is less than 2 centimeters from the central hilum, and therefore it's an adequate location. And as we said, it could also be associated with complications such as knotting and quite distal placement and looping within the right ventricle. Intra-aortic balloon pump, on the other hand, is we all know that it's a device that is used in patients with cardiogenic shock or recent cardiac surgery when they can't be weaned off the bypass machine. And the balloon pump is usually inserted to the femoral artery, either right or the left, and it usually travels into the descending thoracic aorta. The tip of the balloon pump has a metal rectangle tip, and the ideal location of this tip is in the descending thoracic aorta, just distal to the left subclavian artery. And you know the uh, if you have a very high placement of the intra-aortic balloon pump, which means it's sitting right up or quite more proximal to the left subclavian artery, it can result in complete occlusion of the left subclavian artery and cause arm ischemia. If it's too low a placement, then it obviously won't displace enough blood and therefore would not actually improve coronary perfusion and therefore would not actually benefit the patient. So it's important that the tip of it should be sitting as high as possible but distal to the left subclavian artery. As we can see on this particular patient, that's how the intra-aortic balloon pump will appear. That's the arrow which is suggesting the presence of a balloon pump. And if you think about the aortic knuckle and the subclavian artery just arising from close to the aortic knuckle, that's the ideal location of the tip of the intra-aortic balloon pump. Similarly, over here, you can see that there's an intra-aortic balloon pump. The tip of it is sitting just at the level of the aortic knuckle, and it looks like it's an inflated position. As you can see, a hyperlucency around the intra-aortic balloon pump, indicating the balloon is probably in an inflated position in this particular X-ray. Similarly, on this X-ray, again, it's the tip of that is probably sitting just under the left subclavian, and therefore it might be a bit too high for as a placement, and again it's an inflated position. And in this X-ray, the intra-aortic balloon pump tip is sitting. There's a pulmonary artery catheter as well. The intra-aortic balloon pump tip is actually sitting way low, and this obviously is indicative of the fact that this is a very low placement, and this needs to be addressed when you're managing your patient. Now let's look at the other devices that we can talk about while reviewing patients routinely in ICU, and that includes pacemakers and AICDs. Now there are a number of things that we need to know before we talk about pacemakers. One of the most important things that we need to know is the anatomy, and the anatomy as is clear on this particular X-ray or X-ray as well as denotation is the fact that you've got the pacemaker, and majority of them go through the subclavian vein into the superior vena cava, and the pacing wires typically sit in the right atrium, the right ventricle, and patients who've got dual chamber pacemaker a biventricular pacemakers. The third lead usually goes through the coronary sinus and sits on the top of the left ventricle and paces the left ventricle through the coronary sinus. And therefore, it's important that you go through this anatomy before you go ahead and start looking at your X-rays for pacemakers and AICD. Now, we've got varying pacemakers available in patients, and one of the most common ones is a dual chamber pacemaker. But let's talk about single chamber pacemaker first. A single chamber pacemaker is usually rarely seen in patients with atrial fibrillation with an AV block, and the pacing wire typically sits in the apex of the RV. There's only a single lead. There's no evidence of another lead in this particular X-ray, indicating this is a single chamber pacemaker. On the other hand, you can have a dual chamber pacemaker. The dual chamber pacemaker is commonly seen where one lead traverses to the apex of the RV, while the second lead typically sits in the right atrial appendage. Now, there's always, whenever you've got a pacemaker, there's always a pulse generator, which is the box that you see on this X-ray in the left hemithorax. As you can see, the lead that goes to the right apex is actually pointing downwards, while the lead that's the wire that is actually going, or the pacing wire that's actually going into the right atrium actually curls upwards. And if you do a lateral chest X-ray, it typically sits upwards and anteriorly, and that's where the right atrial appendage is, and that's where the pacing wire actually sits. In a percutaneous biventricular pacemakers, on the other hand, there are three leads. So it's a biventricular pacing, as the name suggests, should pace both the right as well as the left ventricle, and therefore you would see both right ventricle as well as left ventricular pacing wires. And there are obviously three. There's a pulse generator. There are three wires that are coming out of the pulse generator. One of them is going into the right atrium and is traveling upwards, as we first noted in the dual chamber pacemaker. So it's actually sitting in the right atrial appendage. Another wire is going into the right ventricular apex, which is sitting down just at the level of the left hemidiaphragm. And the third wire actually goes across the heart and is sitting on the left side of the heart, and that's actually traversing through the coronary sinus onto the surface of the LV, and that's how the left ventricle is getting paced. It's important to know this because it's important that we when we look at pacing wires pacing wires and as well as AICD, that we actually make the right diagnosis based on a chest X-ray when you're describing things. On occasions, you might have patients um, where the surgeons have decided to put epicardial pacing wires, and these epicardial pacing wires are usually placed on the left ventricular apex, right atrial appendage, as well as the right ventricular apex, and occasions left atrium as well. But on most occasions, the left atrium should all that's all needed. So these epicardial pacing wires, obviously the wires have gone on the epicardial surface, so they're not traveling through the veins, and therefore they're just basically on the surface of the heart. As we can see, they're not this particular pacing boxes or pulse generator is sitting in the abdomen, and the wires are actually traveling from the surface of the heart through a subcutaneous tissue onto the pacemaker without traversing any venous system. AICDs, or automated defibrillators, they consist of various combinations of sensing and shocking electrodes, and pretty much what you have when you look at AICDs is that you've got a generator. There's always a tie down, which means it's been fixed, and the wire itself has got shocking coils, so it will appear a lot thicker in both the superior vena cava as well as the right ventricle, and these are called the shocking coils. So you need these shocking coils to call them an AICD. The pacemaker wires don't have these coils, and therefore they're not as thicker in these locations, and this is how we'll differentiate between an AICD and a pacing wire or pacemakers. There are a number of complications that can happen with pacemakers, but things that we can basically easily see on a chest X-ray include misplaced leads or fractured leads, as well as Twiddler syndrome. Say, for example, in this particular patient, the leads look like we would expect the right atrial lead to actually travel upwards once it enters the right atrium. On the other hand, in this particular patient, the right atrial lead looks like it's actually traveling straight down, as well as the right ventricular lead doesn't look too far down into the right ventricular apex, indicating that there is misplaced leads. In this particular patient, there's a clear fracture of the lead at the level of the left clavicle. In this particular patient as well, there's a fracture of the lead, and in this patient, as you can see, the pacing wire is actually wrapped around the pulse generator, indicating this is what is called as a Twiddler syndrome, where the patient has continued to play around with his pacing wires and basically continued to rotate the pulse generator. That's the reason why the wire appears to be wrapped around the pulse generator. Intercostal catheters are the other things that you can visualize, and intercostal catheters can be used for a number of reasons. It could be drainage of pneumothoraces, hemothorax, empyemas, pleural effusions, and the ideal location is that the tip should lie between the visceral and the parietal pleura, and usually the tip of the intercostal catheter lies anterior superiorly for a pneumothorax and usually posterior inferiorly for a pleural effusion or a hemothorax. And important thing when you're looking at chest x-rays is to see if there are any complications associated with intercostal catheters, like if they've had placement of the intercostal catheter into lung parenchyma, into lobar fissure. On occasions, there have been intercostal catheters which are perforated, or especially the pigtail catheters which are perforated the lung and or the heart. Mediastinal, there could be mediastinal or abdominal visceral trauma because the catheters have been placed too low down. On occasions, I've seen people putting catheters through underneath the diaphragm and then actually traverses through the diaphragm into the pleural cavity, and these all need to be looked at when you're looking at a chest X-ray. And on occasions, you can have a re-expansion pulmonary edema. This particular X-ray, you can see an intercostal catheter sitting in the right hemithorax, and it goes superiorly, and therefore this may indicate the presence of a pneumothorax for which the catheter was placed. In fact, I think there is evidence of a pneumothorax, that you can clearly see a pleural line on that particular chest X-ray. There are multiple chest intercostal catheters in this right as well as the left hemithorax for this patient, and there is evidence of significant subcutaneous emphysema indicating this these catheters must be in place for presence of a pneumothorax. The patient is ventilated as well. I don't know if there's any evidence of fractures there, but I suspect this would be a trauma patient. And these intercostal catheters need to be very, on occasions can cause, we said, re-expansion pulmonary edema. In this particular patient, there's evidence, the pre-intercostal catheter, there's a right-sided significant hyperlucency on the right side with minimal midline shift. And there is evidence of an intercostal catheter being placed on the next X-ray. However, the underlying lung appears to be have multiple significant infiltrates, and this patient had significant hypoxia when the intercostal catheter was placed, and this is definitely a presence of a re-expansion pulmonary edema. Now let's move on to the next topic, which is basically presence of a chest trauma. Now, we could see a lot of things in chest trauma that we have already discussed. Things such as pleural pathologies of hemothorax, pneumothorax, hemopneumothorax. They wouldn't appear any different than what we've already talked about. Bony pathology, such as fractures, ribs, scapular and clavicular fractures, or equipments that we talked about already. There may be surgical clips indicating surgical interventions. Diaphragmatic injuries as well as lung parenchymal injuries such as contusions, aspiration, and pneumonia. Let's go through a few chest X-rays. This particular patient, there's evidence of a right-sided pneumothorax, subcutaneous emphysema, presence of significant consolidation on the side of pneumothorax, indicating this probably is. If you provided with the adequate history of trauma, then obviously this may indicate the presence of either aspiration or lung contusions. And the next X-ray, obviously, I think it's been hidden, unfortunately, but you can still clearly see that there is evidence of multiple fractures on the right side, along with presence of significant consolidation or infiltrates on the right side, and this may represent the presence of a lung contusion. The lung contusion is nothing but an airspace disease, which basically represent a hemorrhage into the alveoli, usually adjacent to the point of impact, and it usually does not conform only to lobes, and it does cross lobar boundaries, and this is how you differentiate it from a lobar consolidation. Clearly see in this particular chest X-ray, there's evidence of multiple fractures. Evidence of significant contusion, suggestive of lung contusion. And this particular chest X-ray, there's evidence of again the same kind of pathology. You could see multiple fractures, rib fractures, clavicular fracture or scapular fractures. This particular X-ray, you can see there's evidence of lung contusion, subcutaneous emphysema, possibly multiple rib fractures, both bilaterally. There is possibly a pneumomediastinum, and so on and so forth. Now, when you see X-rays and you want to report on X-rays, what I would suggest is to go back to the stepwise approach that I suggested right at the start, which includes um, going to the patient information, looking at image quality, describing the obvious abnormality, including localization, describing and giving a differential diagnosis, and then going through other findings and structures that you can see, including airways, lung zones, pleural space and costophrenic angles, cardiac shadow, equipment, bones, and then looking outside the chest, looking at humerus, vertebral column, subcutaneous space, and so and underneath the diaphragm, as well as gastric bubble, and so on and so forth. And these things will basically help you to stick to a plan, as well as give a good set of differentials. I think what you should try and do is stick to 3 differentials, and hopefully that would be enough in most of the exam X-rays. Thank you.